السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم آمين وأجمعين. اللهم ارزقني نعمة الإخلاص وجهك الكريم بكل ما أقول وبكل ما أفعل آمين يا رب العالمين. أهلا وسهلا بكم جميعا. سامعيني؟ 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 إذا سامعيني بالله عليكم تكتبوا إنه سامعين صوت واضح. أوكي، سامعين إن شاء الله. أوكي، نبدأ ولا نستنى شوي؟ نبدأ ولا نستنى شوي؟ Okay. This is هذا اللينك. زي ما حكينا هذيك مرة، بإمكانك تأخذ you can get certificate after the session. بس مهم جدا انك تكتب الايميل ايميل واضح، ما فيش فيه اغلاط، لانه في كثير ايميلات رجعت الي على اساس ان الايميل it is failure delivery. واكتب الاسم اللي بدك اياه، يعني انت يطلع بالشهادة. اوكي اوكي we can start in our short discussion cases. Okay. This is the first case. Child with pain, anterior knee pain. What you see? What is your diagnosis? Take some 10 to 20 seconds to see the X-ray of the knee, lateral view, and write your answer. Someone write sending Larson disease. Okay. This is the diagnosis. It is this sending Larsen disease. It is a sort of osteochondrosis like Osgood-Schlatter, and you see fragmentation of the inferior part of the patella, as we see here, inferior part of the patella, and also if we do MRI we have edematous changing and some changes in the patellar tendon, and you see here some sort of soft tissue swelling of the proximal patellar tendon compared to the distal part. So this is the fragmentation due to osteonecrosis of the inferior part of the patella with soft tissue swelling of the proximal patellar tendon. Okay, any question on this case? We move to the second case. Take 10 to 20 seconds to see the case and write your answer. This is T2 and this is after contrast. This is T2 and a plus contrast. We little bit wait for the because this is infective spondylodiscitis. As we see here in the T2, we have a fluid density intensity in the disc space, and the disc space it is decreased, and also some irregularity of the end plates with some edematous changes after contrast, and this is the enhancing of the vertebra of the infection, and this is the collection of the in the disc space and in the plates, and we should drain that collection. So this is an infective process. What is the most common cause of organism in the spondylodiscitis infective one? What is the most common organism? Let us see your answer. The most common organism of this process, biogenic infection, spondylodiscitis, staph. It is the staph. Very good. It is a staph, the most common organism. Okay. we move to the next case, and the next case take 10 to 20 seconds for seeing the case and write your answer. What you see in that chest X-ray? What you see in the chest X-ray? Someone write pulmonary artery hypertension, pulmonary artery aneurysm, pulmonary artery hypertension. Okay. Which part of pulmonary artery is dilated in this patient? Which part of pulmonary artery is dilated? It is the trunk or the main or both? It is the trunk, pulmonary trunk, or main pulmonary artery, or both? Which part of pulmonary arteries dilated as in this patient? Pulmonary trunk, pulmonary main pulmonary artery, or both? Okay, good. Faisal Hamoush, very good. Both. Okay, both. Ibrahim Ayman, both also. Okay, we have the pulmonary trunk and the main pulmonary artery. It is dilated, or both are dilated, and there is a pruning of the pulmonary arteries on the distal to the center. You see here there is no dilatation. Okay, and a pruning يعني كأنه بتقلم الشجرة. Okay, and this the main pulmonary artery and this is the trunk are dilated, and this is a classic case of pulmonary hypertension. Okay, very good. Let us move to the next case. This is 8 years old patient. What do you think the diagnosis? Take some time. Ten to 20 seconds for the answering. Try not to write the abbreviation, because sometimes, okay, adrenoleukodystrophy, this is the correct answer, and this is as you know, this is one of the type of the leukodystrophy, and it is involving the occipital part of the brain and bilateral symmetrical, and if you giving contrast it will enhance also, and it is a sex-linked disease. Okay, very good for this case and the other cases. Write your answer. What is your answer? What is your answer of this traumatic child? Type 2, Salter Harris, Dr. Ibrahim, Dr. Haidar, very good. Dr. Haidar, very good. Dr. Ibrahim, it is Salter Harris type 2. Salter Harris type 2. The correct answer, it is Salter Harris type 2. As we see here in this patient, you have the epiphysis is this one. This is the epiphysis. It is displaced, and you have metaphyseal, also metaphyseal fracture, and this is the classic type 2. You have the epiphyseal plate injury with some displacement of the epiphysis, and we have the metaphysis injury, and this one, and this is a classic type 2. Okay, this is type 2 Salter Harris classification. We have the type 1, we have the epiphyseal plate injury with or without displacement of the epiphysis. Type 2, we have the metaphysis fracture and epiphyseal plate injury. Type 3, we have the epiphysis fracture. Type 4, we have up and below, above and below a fracture in the metaphysis and the epiphysis, and we have crush injury in the type 4. So this is a classic type 2 Salter Harris injury, epiphysis displaced with metaphyseal fracture. Okay, very good. Very good for all of you. Okay, we can move to the next case. This is just X-ray with incidental discolored finding. What you see, and write your answer. What is your finding on this chest X-ray? Here you have the link if you want to take your certificate, and please write your email correctly and whatever your name. Check your email correctly before sending the submit the answer. Right above lobe nodule. Right above lobe nodule. Any description of that nodule? Any description of that nodule? It is lobulated, it is irregular or not irregular, or what is the next step we need for this patient? Someone write hamartoma, zygous fissure. I don't know why they write a zygous fissure, but it's okay. This is the nodule. Okay, right above nodule. What is the description of that nodule? It is lobulated, it is irregular. What do you think? It is calcified or not? Someone write speculated nodule in the above lobe. Okay, someone write speculated. Okay, peripheral location. It is peripheral location. CT is advised. Okay. Okay. We have some irregularity of that nodule. Okay, and the next step it is we want to do CT scan for this patient, and this is the CT scan of this patient. Okay, what do you think? Is that nodule malignant or not malignant, and why? Is that nodule benign or malignant? First, benign or malignant? Is that nodule benign or malignant? Someone write AVM. Someone write irregular, not calcified, malignant 1, Faisal write malignant 1. Malignant nodule. Someone write Zuzu. Okay. Faisal write speculated nodule. Okay. This is a speculated. Actually, this is a speculated nodule. You see here, this is one spicule, one here, one here, one here. This is a speculated nodule. So this is nodule. Most likely it is a malignant one. And also that speculation, we call it corner radiator sign due to dysplastic changes around the nodule. And also we have this one you see here, and this one here. These are the pleural tail, pleural tail. And this also goes with malignancy. So we have two signs here, speculation and the pleural tail. These are goes with malignancy, and the biopsy of this nodule proven to be adenocarcinoma of the lung. So nodule in the lung, we have different differential diagnosis, and the differential diagnosis can be malignant, can be benign. The benignish one, it is hamartoma, granuloma, and the malignant one, we should also do, if there is any signs of malignancy, suspicious malignancy, speculation, pleural tail, this is, we should go for biopsy and see. The calcification, it is more with benignish. Either you have diffuse calcification as in granuloma. In hamartoma you have popcorn calcification, it is or bullseye calcification, and this is, as I said and you said, this is a speculated nodule with pleural tail and consistent with malignancy, biopsy proven it is malignant nodule. And here this is some suggestion from the Fletcher guidelines for the what you see, what is the guidelines for further follow-up of the nodules. Okay, we can move to the next case, and this next case, this patient has abdominal pain, non-specific. Okay, what you see, take 10 to 20 seconds for seeing the care, the abdomen x-ray, and let us see. Okay, what you see in that abdomen x-ray, left renal stone, someone right. aortic. Someone write chronic pancreatitis. Someone write aortic iliac vessels, status post cholecystectomy, calcification in the pancreatic area. Very good, Sergio. This is the calcification in the pancreatic area, also suggests of pancreatic chronic pancreatitis. As we see here, this is the area of the pancreatic calcification, and we see the calcification in the region of the pancreas, and this is a case of chronic pancreatitis, and the patient also has previous cholecystectomy, and the patient has also calcification in the aorta and the iliac vessels. Also, if this is the right one, the left one, and the branches of the iliac vessels, and also calcification of the common femoral artery. Okay, so this is a calcification in the region of the pancreas consistent with the chronic pancreatitis with arterial calcification involving the aorta and involving its main branches. Okay, very good. And we can move to the next case. What do you think? We have two patients with pain, non-specific, and you have one slice in the lower chest and one slice at the level of the pancreas. Take some time and see what is the pathology you can see. We have someone right mass in the head of the pancreas and right lung mass. Both are suspicious. Someone right kidneys, cancer head of pancreas. What is kidneys? Anybody knows what is kidneys? Okay, cancer head of pancreas. Someone right pancreatic mass suspicious. Okay, let us see. As you write here, we have pancreatic mass. This is the duodenum here, and this is the pancreatic head mass. Okay, pancreatic head mass. This is the mass here. But as you see here, there is no significant lymph node, and also you have another mass in the right lung posteriorly with some collapse here, and that mass you have a bronchogram. Differential diagnosis in this patient, as we see here, pancreatic mass can be metastasis to the lung or reverse versa. This is lung mass or metastasis to the pancreas, or someone can put both together. If we can put both together, what is the most likely the differential diagnosis? What is most likely if we can put both together? Okay, what is most likely differential diagnosis? Let us see your answer. Multiple endocrine neoplasia, said one. Well, one of the attendees said, Dr. Hisham said it is multiple endocrine neoplasia. And okay, other differential diagnosis, lymphoma. Someone write lymphoma. Yeah, can be lymphoma. Let us here see. One of the causes of the air bronchogram, other than simple infective consolidation, is lymphoma, and both together can be lymphoma. Other differential diagnosis, Dr. Hisham said endocrine tumor, but with this neuroendocrine tumor is another differential diagnosis. Okay, neuroendocrine tumor is another differential. The main differential diagnosis in this patient, lymphoma and neuroendocrine tumor, as we said before. Also, pancreatic tumor with metastasis to the lung, or reverse versa, lung tumor metastasis to the pancreas. And the patient here proved to have a neuroendocrine tumor both in the pancreas and in the lung. Okay. We can move to the next case. Patient with bone pain. What is your findings? Take some look and see what is your finding on this CT scan. What is your finding on this CT scan on this vertebra? Someone write sclerotic metastasis. Dr. Qais, very good. Where the metastasis? What is this here compared to this here? Okay, this is the pedicle. This is the normal pedicle, and this is the sclerotic destructive pedicle. Okay, and also we have in the anterior part of the vertebra we have another sclerotic area. Okay, and also you have the transverse process here, transverse process here, transverse process, it is sclerotic. So you have metastasis, sclerotic metastasis, and involving the pedicle and the anterior part of the vertebra. What is the source of the sclerotic metastasis? What is the source of sclerotic metastasis? You expect from this patient? From where the metastasis come? What are the tumor give sclerotic metastasis? In male, prostate. In male, prostate, very good, Muhammad. And in female, breast. Okay, very good. Other than the prostate and the breast, is there any other area give sclerotic metastasis other than the prostate and the breast? Other than the prostate and the breast, that give sclerotic metastasis? Thyroid, or someone by thyroid. Thyroid actually giving expanding ballooning metastasis, most likely lytic, and not urinary bladder. Sometimes urinary bladder give, yes. Lymphoma can give sclerotic areas or mixed lytic and sclerotic area. Also carcinoid, bronchogenic carcinoma, yes, can give, okay, sclerotic and lytic metastasis. Okay, these are some of the tumor. Ahmed Dunis give osteosarcoma with calcification, very good. These are some of the tumors giving the sclerotic metastasis. Okay, let us move to the next case. This is MRI of the shoulder. What do you think? شكرا دكتور راتب على التحية. What do you think? It is soft Bankert or bony Bankert? bony or not bony? Okay, as we see here in this axial view, axial slice, and we have the labrum here, completely detached labrum, but the bony Bankart here, it is still intact. Bony Bankart is still intact anteriorly, and you have the complete labral tear. So this is a soft tissue Bankart, not bony Bankart. Sometimes bony Bankart associated with bony Bankart with labral tear, but this is only labral tear, complete avulsed labral tear, and you have the see here the periosteum. It is also cut with the labral tear. So this is a Bankart lesion, not osseous, and this is what here see, it is Bankart lesion, labral tear without osseous in this patient, as in this area, and also we need MRI arthrogram to diagnose the Bankart or Bankart-like lesions. Without MRI, we miss these lesions, and as we see, this is anterior inferior labral tear, complete with scapular periosteum tear, and this is the sketch describing the labral tear here, complete with periosteum cut tear or disrupted periosteum. And most important, we cannot diagnose these tears, labral tear, most of the labral tears, unless we have arthrogram or arthroscopy. But if the patient has some fluid, it will help us to diagnose. But mainly we need arthrogram to diagnose these lesions. Someone write health sac. In this cut there is no health sac. Okay, we can move to the next case. Okay, this patient, what do you think of this patient? Take 10 to 20 seconds for the and to try to spot the pathology. Okay, someone write we cannot understand in Arabic. Okay, we can put it in English. As in the other patient, we have Bankart lesion, and we need arthrogram for the diagnosis. On the next case, we have this patient. What do you think? In this patient, someone write Paget disease, hyperostosis frontalis interna, acromegaly, budget, frontalis interna, intraosseous hemangioma, frontal, Hisham, okay, hemangiocytoma, someone right. Okay, let us see. This is the patient here. We have some thickening of the frontal bone as we see here, and it is the frontal bone thickening more internally rather than in the in the ductal system or outside. So this is the most likely it is a case of hyperfrost- front, front, hyperstosis frontalis interna, and we want to confirm that, and this is the confirmation of the patient with the CT scan, and you have thickening of the bone, internal thickening of the bone with almost symmetrical in both the frontal region, and this is a classic case of hyperostosis frontalis interna, and it is common in female and sometimes discovered incidentally, and sometimes it is associated with endocrine abnormality, okay, and obesity. So this is a case of hyperostosis frontalis interna involving both frontal bones, and also in the CT scan it is a classic for hyperostosis frontalis interna. Okay, there's sometimes some syndromes associated with this condition. You can check the box for these syndromes. Okay. Okay, this is another patient. Take 10 to 20 seconds for the to see the case and write your answer. Okay, what is your answer in this patient? This new patient, what is your answer? Bony metastasis, sober scan, axial skeletal metastasis, sober scan, bone scan with multiple metastasis. Okay. Okay, this patient, as we see here, this is bone scan, and we have multiple hot areas involving spine, dorsal spine, ribs, multiple ribs, shoulder, neck, upper neck, and region of the left sacroiliac joint and right sacroiliac joint, and this is the bone scan with metastasis. And here this is the right side, and the metastasis on the left here, on the right here, and right sacroiliac joint, iliac crest, and multiple rib metastasis. Okay, this is a bone scan with multiple metastasis. With normal bone scan, we see some sorry, we see some kidney function, and in this we don't see any kidney function because of from metastasis. Okay, so this is a classic case of bony metastasis with bone scan. Sorry. We move to the next case. What is that next case? Take 10 to 20 seconds for the next case, and let us see your answers. What you see in this CT scan, if you can also write the radiological sign on this CT scan. What is the radiological sign, and what is the diagnosis? Dr. Abdullah, he write Mount Fuji sign. Mount Fuji pneumocephalus, it is not correct answer. Okay, in pneumocephalus it is not correct answer. Pneumocephalus alone also it is not a correct answer. You should write tension in pneumothorax, tension in pneumocephalus. Okay, tension in pneumocephalus, and the sign it is Mount Fuji sign. So this is tension. Why tension? As you see here, this is the air in the subdural spaces bilaterally going to the interhemispheric fissure here and compressing the frontal horns. Okay, these are the frontal horns, frontal lobes, and giving the appearance of peaking, giving the appearance of Mount Fuji sign. This is the Mount Fuji and in South Africa, and this is the sign. You see here the frontal lobe, it is peaking like this mountain, and also the other, and it is compressed by subdural air. Okay, so subdural air in the interhemispheric area compressing the frontals, giving the appearance of peaking and giving the appearance of Mount Fuji sign. So this is a tension in pneumocephalus. Tension in pneumocephalus. Pneumocephalus alone, it is not correct answer, and it is a surgical decompression need. it is a surgical decompression, we need the surgical emergency. Okay, so this is another patient. What is your diagnosis? Diagnosis, everyone know that it is a hemangioma, but we want the what is the name of the sign in the axial cuts, and what is the name of the sign in sagittal cut? What is the name? Everybody, I said everybody knows. Sign as we see here, or salt pepper appearance if you want also, and this is the striation, vertical striation, this is the corridor sign. Is there any other things with this patient? What is this? Here. What is this in the on the right side? What is this on the right side? Arrow. What is this here? What is here? Anybody? What is this? Okay, someone write gallstones. Yeah, it is gallstones. Okay, we can move. Here you can open this link and open this link and see, write your email correctly and your name, and you can obtain your certificate immediately with this link. Okay, before we close, this is, you can take the link and copy the link and fill the required your name and your email, write it correctly, and you can obtain your certificate of attendance. What is this? This is the last case, our last case. What is this? It is simple. You can hear me? You can hear me? No connection? Why? So this is the case of tension in pneumothorax. Very good, Haidar. This is tension in pneumothorax. Take the link and fill the required areas, your name and email, and you can obtain your certificate. Okay, this is the last case, tension pneumothorax, and this is the link. You can open the link and fill the required email and your name. You can obtain the certificate. في صوت هشام فتياني سامعني؟ Okay, we can stop sharing.